Welcome to session 8 of BIOP. In this session we're going to look at first drugs that affect the blood, then move on to drugs affecting the gastrointestinal tract, and then finally into lipid lowering drugs. So when we talk about drugs affecting the blood, we're going to talk about antiplatelet drugs, anticoagulant drugs, and thrombolytic agents, going through their actions and adverse effects. In the gastrointestinal system, we're going to focus on the upper gastrointestinal system, looking at drugs that affect acidity levels in the stomach, and then also some antispasmodics and antiemetics. And then we'll move into drugs that, again, lower lipid levels in the body, with a few different classes of drugs that we'll cover there. So we're starting with drugs affecting the blood, and we're mostly looking at, or we are just looking at, drugs that affect hemostasis within the blood. So hemostasis is what we call the mechanism that prevents blood loss when a vessel has been damaged, that stops blood flowing out of a damaged vessel. So there's 3 key components to hemostasis. Whenever you need to form a blood clot, you have to have a vascular spasm to narrow the blood vessel. You need the formation of a platelet plug, where platelets become activated and adhere to one another in order to create a clot structure. And then you also have blood clotting, also called coagulation. And this is where you get the activation of clotting factors, leading to the formation of fibrin threads, so protein fibres that reinforce the clot structure. So this is a normal response to damage to blood vessels that prevents the blood from leaking out of the blood vessels. So this is how we stop ourselves from bleeding. However, each of these steps can occur in the absence of bleeding. So they can occur when the blood has become static, blood stasis, and that's linked to things such as deep vein thrombosis, where you've had stationary blood in large veins, and the static blood will begin to form a clot. That clot can then be ejected to other tissues and cause things like strokes or pulmonary embolisms. And most commonly, you also have clots occurring without bleeding with atherosclerotic plaque ruptures. So atherosclerotic plaques are where you build up those fatty plaques in the wall of a blood vessel. This tissue is generally not as strong as the normal blood vessel wall, and so it tends to fissure or even more severely rupture, leading to the exposure of some of the underlying tissue of blood vessels, tricking the blood into thinking that there is bleeding occurring, even though most of the wall of the blood vessel is still intact, and that can lead to a clot forming where it's not necessary. And if inappropriate blood clotting continues unchecked, it can occlude a blood vessel, blocking the blood flow to tissues, resulting in ischemia or a lack of oxygen and consequent damage in that tissue, and potentially tissue death. So this is the mechanism in heart attacks and in the majority of strokes as well. It's aberrant blood clots forming. So to control for the incidence of heart attacks and strokes, we want to control that clot formation. So to understand how the drugs work in this, we're going to see that we have, and we'll need to look at some of the details of that hemostasis process. So if there's been damage to a blood vessel, either causing bleeding or simply damage to the wall where there's an atherosclerotic plaque, you're going to get some blood starting to leave the blood vessel if it's fully broken, and you're going to get exposure of underlying tissue. Collagen in the connective tissue underlying the endothelium is a common one that triggers the clotting process to occur. This includes both the release and activation of clotting factors, mostly activation. They're already present in the blood, and they each activate each other through a cascade of steps, leading to these last couple of steps that are shown here. So here prothrombin is converted into the active enzyme thrombin, and thrombin acts on fibrinogen that's always circulating in the blood converting soluble fibrinogen into insoluble fibrin threads. At the same time, platelets have become activated. They adhere to each other and to the surrounding tissue and red blood cells in the area, forming the actual platelet plug that is going to block the hole in the blood vessel, and that is then going to get reinforced with the fibrin threads that have been created by the clotting cascade. So you get an overall development of a clot that is insoluble and blocks the leaking of blood out of the blood vessel. So you can see this clot here is mostly in the vessel wall. If the vessel wall has not been completely broken, but instead it's an atherosclerotic plaque that's fissured, most of this blood clot is going to be in the blood vessel itself and can become large enough to occlude that blood vessel. So we tend to target one or the other aspects of hemostasis, main aspects of hemostasis, either the platelets or the clotting cascade. For the antiplatelet agents, they look to disrupt some aspect of the signalling involved in platelet activation. So you don't need to know all of the detail on this slide, don't worry, but we're just pointing out here that there is a lot of chemical signalling, activation of receptors and intracellular actions that lead to the activation of platelets that go from their circulating form into this sticky form that clumps together with each other and with red blood cells and binding to fibrin and fibrin threads as well. So lots of different signalling molecules. You might recognise some like ADP, lots of different receptor types. We can see exposed collagen from a damaged or ruptured atherosclerotic plaque here is part of what's activating platelets. But lots of contributing factors is the point, and we have quite a number of drugs shown in the red that are able to block some aspect of this activation process. The one we're going to focus on is one that we actually know quite well, where part of platelet activation is the fact that platelets use the enzyme COX-1, cyclooxygenase 1, to create thromboxane A2, another signalling molecule we recognise, which then in turn activates that platelet. It gets released by the platelet, activates that same platelet and also other surrounding platelets in order to further activate that platelet and activate other surrounding platelets. So we know that COX-1 can be blocked by non-steroidal anti-inflammatory drugs, particularly by aspirin, that irreversible inhibitor of cyclooxygenase. So that's going to be the one that we focus on. So our example antiplatelet agent aspirin then has its mechanism of action in that it irreversibly inhibits cyclooxygenase enzymes, and the COX-1 enzymes in particular are required in platelets to make thromboxane A2. So if we're looking in a platelet here, COX-1 is going to be one step in the process in making thromboxane A2 that platelet will release, that will then lead to activation of that platelet and others. We use aspirin in particular because it's able to have this long-lasting effect on platelets because it's an irreversible inhibitor. So the platelets, being just a fragment of a cell, don't have a nucleus, and as they don't have a nucleus, they can't resynthesize any enzymes that have been permanently inactivated. So the effect on platelets is long-lasting. You need to make new platelets before the effect is stopped. So taking a low dose over time will mean you have a limited number of activatable platelets in the body. So therefore we use aspirin for prophylaxis and treatment of disorders of abnormal clotting, such as transient ischemic attacks, where you get brief stroke-like symptoms, thromboembolic disorders, after any heart valve replacement, where you've got this highly thrombogenic surface being added into the heart, and other disorders of coagulation as well. So the adverse effects are those same ones we discussed back in session 6 when talking about aspirin as an anti-inflammatory and analgesic drug. Same kinds of adverse effects, just remember they're more limited in incidence and severity because lower doses of aspirin are required. Also remember the key difference with aspirin as an antiplatelet agent and aspirin as an anti-inflammatory is exactly which of the COX enzymes is being targeted. For antiplatelet effects, you're targeting cyclooxygenase 1 and you happen to block some cyclooxygenase 2 as well. And for anti-inflammatory actions, it's the reverse. You aim to block cyclooxygenase 2, happen to block some cyclooxygenase 1 as well. So then the anticoagulants are those that target the coagulation cascade, the blood clotting process that leads to the fibrin threads. So these are drugs that are used to prevent clot formation, just like the antiplatelet drugs, but target a different part of the hemostasis process. They don't have any effect on clots that have already formed, so they don't change fibrin threads that have already been made. They just look to stop you making more fibrin threads. As well, an important thing to note about anticoagulants is they're not going to repair any ischemic tissue that has already been damaged. So they're mostly used as a prophylactic or preventative therapy, preventing new clot formation in patients who are at risk. So this is patients who've had a heart attack, patients who are experiencing atrial fibrillation. That is a condition where you have improper contraction of the cardiac muscle cells of the atria. It can happen with age-related damage to the heart, and so is common in very elderly people. And it tends to cause areas of stasis of blood in the heart, which can lead to clotting. You also have it used for where there's been pulmonary embolism. It's not going to break down a clot that's already blocking the lungs, but can stop more clots forming and adding to that embolism, and also used in any coronary occlusions as well. So we've got two main groups of anticoagulants: our parenteral anticoagulants that have to be injected, and that's generally heparin, and our oral anticoagulants that can be taken simply as a tablet, and that's generally warfarin. So to examine how these anticoagulants work, we're going to give a little bit more detail to the clotting pathway that we saw a simplified version of before, where clotting factors led to the creation of fibrin thread. So coagulation occurs through one of two pathways, both of which end up in the same place, where you have a number of circulating clotting factors in the blood. And these are all numbered with Roman numerals. The numbers don't go in order though, because they were all numbered in the order they were found rather than the order that they occur in the pathway. But you find these factors work in a way to activate each other. So for example, factor 12 here becomes active factor 12, which in turn activates factor 11, which in turn activates factor 9, and so on and so forth, with amplification of the system at each step of activation, leading eventually to the activation of circulating prothrombin into active thrombin, which is what actually converts fibrinogen into fibrin threads that are going to reinforce a clot. On this figure here, we can see where our two groups of anticoagulants actually act. Our heparin is going to inhibit the activation, inhibit the factors when they're activated that are depicted here in the lighter colours. So all of these active factors and the thrombin itself are inhibited by heparin. And warfarin belongs to a group called the coumarins. And instead of inhibiting the activated factors, the coumarins, like warfarin, actually stop you creating the inactive factors that are already circulating in the blood. So they're not there present to be activated for a clot to actually occur. So they do this through slightly different mechanisms, or quite different mechanisms. Heparin, its mechanism of action, is that it's being administered, you administer heparin, which is actually an endogenous compound as well, and its normal role is in the inactivation of clotting factors. It's a polymer substance that's able to actually reinforce the structure of antithrombin interacting with coagulation factors, or those ones listed on the previous slide. So antithrombin is a circulating enzyme that normally acts to inactivate clotting factors after they've been activated. It's normally a slow process, and it's just one of the normal caps on the clotting process, so it doesn't get out of hand in the normal situation. If you administer a lot of heparin though, this process happens much more quickly. You reinforce this association between the antithrombin enzyme and active clotting factors, making them into inactive clotting factors. That inactivation occurs, and then the heparin itself can be then freed to go and do this for another clotting factor. So a small dose of heparin can inhibit a large amount of clotting. So this is used as the initial therapy for deep vein thrombosis, pulmonary embolism, and any acute arterial occlusion, where you don't want a clot to be able to get any bigger or any more clots to be able to be formed by whatever's triggered them in the first place. So the adverse effects of this can of course include bleeding if you're inhibiting the clotting process, and therefore you're stopping all blood clotting, even normal blood clotting, for when bleeding is occurring. Some people can have a hypersensitivity and have an allergic reaction from their immune cells targeting that heparin. And you can also see a thrombocytopenia or a low platelet count resulting from this as well, from the lessening of coagulation factors that would normally regulate that number. This is contraindicated in any threatened abortion where there is risk of miscarriage already occurring. Any visceral carcinomas could be worsened during or after surgery, particularly in areas like the brain, spinal cord or eye, where bleeding is of particular risk. And similarly, if you're going to look into introducing into the central nervous system some puncturing influence, like for a lumbar puncture or a regional anaesthetic block. And if you've had this heparin-induced thrombocytopenia before, you generally shouldn't take it again in the future. Warfarin was the drug that, instead of targeting activated clotting factors and inactivating them, actually stops you making the clotting factors in the first place. So we've got a little bit of confusion of terminology here. It stops you making active clotting factors. By that we don't mean activated clotting factors that are participating in making a blood clot, that are participating in coagulation at the time, but simply stops you from making the clotting factors into the final form that they circulate in the blood in, where they can be active, where they can be activated. So it stops you from making normal clotting factors. So it does this by disrupting a biochemical pathway that's normally the last step in making the clotting factors that are going to circulate around in the blood, the inactive form of those clotting factors. So you make a clotting factor, which is a protein, a polypeptide chain, and before it's the final clotting factor that's going to actually be able to become activated when coagulation happens, you have to do one last step where you do a reaction that carboxylates or adds a carboxyl group to all of these clotting factors. And this reaction relies on the presence of a reduced form of vitamin K, that is, chemically reduced form of vitamin K. And reduced vitamin K participates in this reaction, becomes vitamin K epoxide, an oxidized form of vitamin K, and then normally that vitamin K is recycled and used for another reaction. So vitamin K just keeps flipping between these two forms, becoming the epoxide, being returned to a reduced form, becoming epoxide with a clotting reaction, becoming the reduced form. And all of this is going on in the liver when you're making the clotting factors that are going to circulate around the blood and wait for blood clotting to be required. What warfarin does is stop you recycling the vitamin K. It's a very similar compound to vitamin K, an analogue of vitamin K, and sometimes people refer to it as a vitamin K antagonist, because what it does is block the enzyme that normally recycles the vitamin K into the useful form And so without the useful form of vitamin K, you can't do the final step in making clotting factors, and particularly the clotting factors numbers 2, 7, 9 and 10. Without these clotting factors, you greatly disrupt the clotting cascade, and therefore you cannot create a normal blood clot, or you cannot create the same degree of blood clotting within the body. Now, the issue with warfarin is that it has a very narrow therapeutic index. You'll see it come up again and again through our lectures in lists of drug interactions. We pay a lot of attention to drug interactions with warfarin because of this narrow therapeutic index. It's very highly protein bound, and just a little bit too much is going to cause excessive anticoagulation, meaning that you can't form normal clots that are required, and just a bit too little is not going to have the effect of stopping the aberrant clots that you're trying to stop. So you need to get the dose exactly right, and any drugs that disrupt the level of warfarin by competing for protein binding or disrupting its metabolism are going to then potentially lead to adverse effects with warfarin or stop warfarin from working. The adverse effects that might occur are mostly related to excessive bleeding. So mild ones would be things like easy bruising, whereas serious ones are going to be abnormal bleeding, such as heavy or persistent menstrual bleeding, blood in the stools, vomiting of blood, severe nosebleeds that are very difficult to stop, risk of brain hemorrhage as well. So these are things that can happen if the dose is too high of warfarin, and getting the dose just right is difficult because of the narrow therapeutic index. There are other reactions that can happen to do with gastrointestinal disruptions and hypersensitivity reactions such as rashes, itching and other allergic reactions. So because of the requirement for a very narrow, to keep the warfarin level within this narrow therapeutic index, you have to be very careful with any drug interactions. So there's lots of different drugs that might increase or decrease its effects. That's going to include a number of things such as those listed here. If you have anything else that's going to affect blood clotting, such as aspirin, then you're going to end up with a potentiation of its anticoagulation. Anything that's going to increase the levels of warfarin by inhibiting its metabolism, including high amounts of alcohol that lead to acute alcohol intoxication. All of those are going to potentiate anticoagulation. And you're going to stimulate more metabolism of warfarin with a number of other drugs, meaning you get less anticoagulation and potentially go back to getting your abnormal clots that you were trying to treat, including chronic alcohol ingestion and a number of other drugs that stimulate the metabolism of warfarin. So alcohol is generally recommended to be avoided, either as an acute intoxication or just a chronic ingestion of alcohol. And there is a long list of drugs that are going to interact with its metabolism. As well, there is a number of effects with interactions with herbal preparations. So there are a number of things that either act on clotting as well, or that are able to interfere with its metabolism, like St. John's wort. And we also have a number of states in the body that are going to affect coagulation. Things like hyperlipidemia and hypothyroidism are going to decrease coagulation in the body. You certainly shouldn't take it in any cases of active bleeding in people who have aneurysms or cerebrovascular bleeding. It has to be avoided during surgery, so you'll see people going off their warfarin before a surgery occurs. It's going to be a problem if there's been any severe trauma, severe uncontrolled hypertension where you can get damage to blood vessels occurring, and the damage to blood vessels that comes with things like severe diabetes. And you'll also see vitamin K levels interacting with warfarin. So because it's so similar to vitamin K and because it's acting on an enzyme that uses vitamin K, increase the amount of vitamin K, you decrease the effect of warfarin. Decrease the amount of vitamin K and you increase the effect of warfarin. So it's important that people have a fairly steady intake of vitamin K if they're taking warfarin. Contraindicated in early or late pregnancy. Early pregnancy bleeding is likely to lead to miscarriage. Late pregnancy, you have risks of bleeding in labour. Now, because of all of these interactions in the narrow therapeutic index, you constantly monitor the blood clotting capability of people who are using warfarin. So you have this standardised test that leads to a number called the International Normalised Ratio, and warfarin doses are always matched to keeping that number in the right range so that you've got sufficient anticoagulation to stop abnormal clots without having too much anticoagulation where you would cause excessive bleeding. So for both heparin and particularly warfarin, there is always risk of hemorrhage occurring. So because of that, you'll have things like warfarin being discontinued in advance of any known planned elective surgeries. Heparin will usually be given in those cases instead because it has a short half-life compared to warfarin, and we also have drugs that reverse the effect of heparin as well. So they act as like heparin antagonists, and so these are able to immediately during surgery, in case of bleeding, reverse the effect of heparin. You don't tend to take people entirely off anticoagulation as they find mild anticoagulation is appropriate for surgical operations, where sometimes the danger can more be from abnormal clots forming after surgery rather than from bleeding during the surgery itself. With warfarin in particular, spontaneous hemorrhage can occur though. Having just too much of it, dropping the vitamin K in your diet, having an interaction with another drug, can suddenly lead to too much warfarin in the body, a spontaneous hemorrhage occurring, and the incidence of this occurs at a rate that there's very well-defined guidelines for managing these spontaneous hemorrhages. They give you big doses of vitamin K to antagonise the warfarin that's already in the body, and they'll also give you fresh frozen plasma concentrates, so from other people's blood plasma, that is going to include a lot of clotting factors in it, and so that you'll be able to use those clotting factors to stop the hemorrhage.